So thank you everybody for joining this webinar. We are hoping to be able to give you a bit of an update on best practice and some insights and learning about work that's going on about children and young people's mental health waiting times. This is the agenda. So I'm Kathy Lavella. I'm a consultant child psychiatrist by background, and I'm medical director for children's services in East London Foundation Trust in London and for the North Central East London CAMHS Provider Collaborative. And I think one of the case studies that you're going to be hearing from is about one of the services that I have responsibility for, although I have nothing to do with it. It's all down to the leads that you're going to hear from later. What we'd like to just kick off with is a little bit of basic housekeeping. So welcome everybody, thank you for joining. Whilst you're on the call, we ask that people keep themselves on mute and keep yourselves off camera, just because it makes it easier for teams when they're presenting. We will be recording the webinar, and I think the recording, if this is right, Jen, the recording will be circulated along with the slides once the event is over, so you don't all have to be frantically taking notes as we're going along. What we're aiming to do is two parts really. So the first is to give you a bit of a scene setting, really thinking about what's going on nationally around this important piece of work. We know that there is a big focus for children and young people's teams about waiting times. We know there's increasing demand, certainly in my own services. I think we've seen a doubling in estimated prevalence of young people's mental health problems over the last 6 to 8 years, and associated increased demands in crisis, for eating disorders and for neurodiversity assessments. So, and I'm sure that that's the national picture as well. So we know that everybody's struggling with this. What we would like to think about is give some advice and information and share good practice around how to address data quality, developing plans to address the longest waits. And we also will be getting some updates on national policy and requests to the system from NHS England, and getting a bit of an overview about the national offer and regional support offers around this. And this will kind of go back over some of the information that you might have already seen put out to the system fairly recently. So that's going to be the first part. And then afterwards, we're going to be doing sharing some insights, sharing some good practice and some learning by presentations from two services, one from London and one from Northumberland, I think, talking about their experiences, and hopefully we can have a bit of discussion around that and think about what people can take from this, what other good practice exists out there. We are going to start off with Beth McGeever, I think, talking from London. And hang on a minute, I've lost my train. We're going to start off with Grace Harding. Sorry, that's my mistake. I've got it wrong. Grace Harding, who's the Programme Manager for Children and Young People Mental Health at NHS England. Sorry, Beth, if I gave you a fright. And Grace is going to kick off giving us a bit of an update on National Children and Young People's Waiting Times Policy, current priorities for the system, and a little bit of an update about what support is available from NHS England. So I think if that's okay, I'm going to hand over to Grace.
Thank you so much, Kathy. Hi, everyone. For those that don't know me, yes, so I'm Grace Harding, a programme manager in the National NHS England Children and Young People's Mental Health team. Some of you who were on the recent London webinar, I think a couple of weeks ago, will be very familiar with these slides, but we've found that repetition is the best key, because this is a very complicated topic and there's many different elements to it. So if I could go to the next slide, please. So I thought I'd just start off with some clear definitions, because as I said, it is very complicated and there are many different elements, both to the waiting times metric. We have longest waits, we have kind of a different methodology for different metrics. So firstly, when I talk about the full community mental health metric, I'll show some diagrams on the next couple of slides. They are the ones that have the clock stops. It's the new metric that we started publishing data on in September this year that we will use in the future and have kind of many different elements to them. Single referral is measuring waiting times using only one referral. Referral spell is a way to eliminate the issue of multiple referrals sort of skewing data. And what we've done for referral spells is to connect two referrals for the same person within 5 days in the same provider together to try and reduce some of those multiple referrals and create more of a kind of direct line representing someone's pathway. As I say, it's only within 5 days and only within a provider at the moment. And there are plans to look at further developing that for multiple providers in the future. And what we've done with referral spells is the full metric and the new 104-week waits data is using that referral spell, whereas previously when we reported on waiting times using the 90th percentile and median data, that was just using the one single referral methodology. So we're trying to move forward to that referral spell in the future. Contact-based, so as opposed to the full metric, which is what we would like to use in the future, of which, because we've only just started reporting on that, and we know that services are only just implementing it. You know, it'll be somewhere down the line of data quality being appropriate to use that measure. We're using contact based. So for children and young people, that's one contact. And for adults and older adults, that's 2 contacts. And that's mirroring what we currently use for access. So the 104-week waits and the 90th percentile longest waits, when we refer to longest waits, it is using that contact-based methodology. I think the others I've sort of touched on, but I just wanted to sort of have that clear line that full metric is aspirational. We are reporting on it, but it's something for the future. And at the moment, because of working with the data that we have, we are looking at that contact-based referral spell data. If I could have the next slide, please. So as I said, these 2 next slides are hopefully familiar to everyone, so I won't spend too much time on them. They are visual representations of the new full community mental health waiting times metric and the components that are required to stop the clock. So for the adult community mental health waiting times metric, a referral is received, and then to stop the clock, a meaningful assessment takes place, an outcome measure is flowed, and one of those, either in a clinical or a social intervention or a co-produced care plan. So it's a compound measure in the sense that those 3 elements are required to stop the clock. And if I could go to the next slide, please. And then for children and young people, once again, the clock starts when a referral is received. Slightly differently, the clock is stopped when an intervention, SNOMED code, and an outcomes or experience measure are both flowed to the MHSDS. So one less step. Both the adult and the children and people's mental health metric use SNOMED codes that are found in a SNOMED reference set that we've been developing. Again, if people aren't aware of that, I can share some links in the chat after this. And that it is within that ref set, those codes are what stop the clock, with a small tweak being for the children and young people. In the assessment part of the reference set, it is only autism and ADHD assessments that stop the clock. If I could have the next slide, please. So this is just a list of the available metrics and sort of picks up on how I started the presentation. I wanted to highlight again that the lines in the kind of turquoise colour that are standing out are the two metrics that we nationally are focusing on at the moment. So as mentioned, whilst we have published data on the full clock stop, we're also aware that the data quality is pretty poor at the moment because we know services are implementing it and it needs those SNOMED codes and sort of flowing new bits of data. So our focus at the moment is reducing those longest waits. Well, actually, I'll wait to go into further slides to sort of demonstrate why. If I could have the next slide, please. Yes, so this further emphasises the point that we appreciate that data quality is poor, and for this very reason, whilst there has been mentioned in past, and it might be touched on in presentations later today, that this work for children and people started with the 4-week wait pilot. At this point in time, we are not putting any standards or improvement management trajectories or targets on the full clock stop metric. As I say, once again, our focus is on those longest waits, those 104-week waits, and to build that narrative of why there are longest waits and improvement trajectories. So what we've asked with that focus on longest waits is that systems focus on closing historical open waits. And we've also added that, as I mentioned, for adults, an assessment code is needed to stop the clock. And we've put in a process whereby any assessments that took place before April 2024, it's just the two elements moving forward that can be used to stop the clocks, so that people aren't having to do assessments all over again, which we know aren't clinically meaningful. If I could have the next slide, please. So why are we focusing on longest waits? Well, both the data quality of the full metric, but also there was a line in the this year's operational planning guidance that asked systems to focus on longest waits in CYP and adult community services, as well as adult UEC. Hopefully people on this call may be aware that a couple of months ago, the national team sent out a template, an Excel, asking systems and providers to focus on their 104-week waits. If there aren't any 104-week waits locally, they're 78 weeks or they're 52-week waits. And asked for both a trajectory until the end of 25-26 and an improvement trajectory till the end of 24-25. One of the things I'll say now, and I do appreciate it's late in the day, but we are building a kind of lessons learned log that we're going to discuss after this piece comes to a close, is the improvement trajectory. We have only asked for the end of 24-25, and that's because that's the period covered by the planning guidance, and it didn't feel fair to our systems and providers to provide trajectories beyond that date, especially with no additional funding attached. And again, this is looking at the contact-based metrics using that referral spell methodology. So if I could have the next slide, please. So these next two slides, these will be shared so you can look at them in more depth, but I really just wanted to show them to show the difference between the data we're seeing for the full clock stop, so that's the full metric, and two contacts in this instance for adults, so the contact-based metric, to just show the disparity at the moment in what we're seeing between the two, which is why we're still focusing on that contact-based data as opposed to the full clock stop, because we know that there's still a lot of data quality issues and it's not necessarily reflecting a true image of what's happening locally. So I'll go to the next slide as well, because that's for children and young people, but I think that's one that perhaps you can review locally, and to give ease some concerns about the full clock stop and about standards that, we know that there's still a long way to go for the full metric. If I could have the next slide, please. So this is just an update on kind of what we've done so far and what our plan is for the future. So as mentioned, the 104-week wait template is due on the 8th of November, so that's this Friday. We are planning to collate all those returns. There's text for narrative to explain longest waits, and we are going to collate all of that and report it back to our leadership group and work on some next steps from that. I've just briefly looked at the chat and I will answer those questions. I'll type after my section's over. For children and young people, the 104, the contact-based data does include, well, is likely to include learning disability and autism services because it is contact-based. We are fully aware, and I have already said that I'm expecting 42 returns saying that their longest waits are associated with these cohorts of children. I appreciate people's frustrations, I really do. I think we have been trying to share this with other colleagues, and I think this will be the first time we'll be able to have that true narrative from providers, from systems that we can put in front of people and say, this is where the weights are. I appreciate it, it's a first step along the journey and it's something that people are struggling with locally, and it's not nice, having to answer a template when the weights aren't necessarily mental health weights that you're responsible for. But to know we acknowledge that and recognise it, and hopefully, and it'll be the evidence that we can then put forward. And then past reviewing the 104-week wait template, we're also looking at, so via the 104-week wait template, we've acknowledged that there's several aspects of the data and the methodology that perhaps we weren't aware of, the new service models we weren't aware of, that we need to kind of review the coding and address. So my plea to you all is, thank you very much for bearing with us. Thank you very much for highlighting all those issues. We don't know what we don't know. And please do keep contacting us and sharing things. We've had to try and implement something nationally, and we understand that services are configured very differently across the country. And we can only try and kind of find a way forward or look at the code and the data when we hear from you and understand that narrative. And there are kind of things we definitely have a long list of things we want to do next, but I think it's about tackling those issues that you're putting forward and your colleagues are putting forward now that have come out via the 104-week wait templates and the metric construction. So we don't want to run before we can walk. So sorry, I think I may have gone over time, but I will also answer questions. I'll be here for the rest of the meeting and answer those questions that are in the chat. So thank you.
Thank you so much. That's really helpful. And I know that this is something that's causing a lot of anxiety for everybody at the moment. In fact, I was on a meeting this morning talking about exactly this. So what I should have said and didn't say was, could everybody put their questions in the chat, which I can see that they are doing, and then hopefully we can pick some of these up in the Q&A in a little while. I have to say, I do think it's in principle, I like the idea of moving to a metric around meaningful help rather than just access, but it's how we can measure that meaningfully. And you can see all the anxiety in the, understandable concern around what this means to services in the chat. So it'd be really helpful to have an opportunity to ask a few questions about that in a minute. So thank you very much. We are now going to very quickly move on to Beth, who I frightened into thinking she was going early a minute ago. So Beth is a senior program manager for the London region for NHS England, I think, if I've got that right. And Beth is going to give us an update on priorities for the region and the support offer from NHS London. So Beth, are you there?
Hi, yeah, thanks so much, Kathy. So I have just got 2 slides to canter through this afternoon. So moving on to, technically I've got 3, but this is just a title slide and one saying if you've got any questions about anything in the presentation, contact our shared inbox. So moving on to the next slide. So this slide here, I guess, just plays back some of the reasons why we feel it's really important for us to have a focus on waiting times across the region. I think it's safe to say that tackling waiting times across adult and children and young people's community mental health services are a really key priority for us in the London team, and we've been doing quite a significant amount of work to support providers and ICBs following the publication of the recent waiting times metrics and the ask that Grace mentioned around developing trajectories, which I'll come on to in a little bit. But I guess this slide here, which Grace probably recognises, we've built on one of the national slides for this, just sets out, I guess, some of the reasons why we think measuring waiting times is so beneficial and so needed so much across the region. So we know that the length of time that people can wait to access mental health services can impact their experience and their outcomes. We know that measuring waiting times can help us to support systems to deliver timely and appropriate care. And I guess having appropriate data quality in place really helps us to understand the true extent to which people are truly waiting for services and kind of specifically what care and support that they're waiting for. We know that the data captured around waiting times can be used to support systems to address health inequalities. We know that data helps us understand local and regional variation and also examples of good practice. And it also helps us to demonstrate, I guess, crucially, the impact of investment in mental health, and really supports us and national policy teams with making additional requests to the government through spending reviews and kind of other processes to access additional funding. And finally, waiting times can help us to understand the change in demand across systems and identify support and any necessary resources. I actually think it's really beneficial that we've started to look at waiting times data more closely across mental health over the, I guess, we've started to have much more of a focus on it over the past couple of years. I think it's really impactful to look at access and understand how many more people we're seeing, but actually the true benefit is understanding how long people are waiting to access kind of what is being described as meaningful help. And I think if we reflect on the journey that their mental health has been on over the, I guess, like the past decade, we've probably gone from being able to have a very limited understanding even of how many people are accessing services to now we're at the point where we're starting to look at some of the waiting times data. And I think kind of reflecting on Grace's point, I think we recognise that there are lots of challenges with the data, and it's going to take a long time for understanding of the metrics and to bed down in systems and for us regionally. But I think it's a really exciting opportunity for us to be starting to interrogate this data in a more meaningful way. So the next slide, moving on, just sets out some of the work that we've been doing regionally over the past couple of months. So I won't recap the top section of this presentation because I think this basically repeats what Grace had said about the publication of the waiting times metric and also the ask out to systems around submitting trajectories for eliminating those longest contact-based waits for adult and children and young people's community mental health services. Just to flag there, we had a slightly earlier regional deadline for the submission of that as well. The trajectories are due to us by close of play today. So just moving to the timeline at the bottom of this slide. So in September, NHS England published a suite of new metrics for both full clock stop data for adult and CYP community mental health and the contact-based clock stop data as well. And that was when the ask came out to systems to kind of start reviewing the data and setting trajectories around reducing the contact-based clock stop waits for adult and CYP community mental health services. And I guess the kind of second ask as part of that was to start to think about improving data quality for those full clock stop measures as well. I think, like Grace said, the the percentage recording of each of the individual clock stop elements at the minute is probably not of sufficient quality for us to be able to get a true understanding of how long people are waiting for that meaningful help. In October, there was a national waiting times webinar, and then we also ran a specific session for the London region, a community practice around waiting times. And we've also shared out with systems a regional SQL script for referral spell contact-based metrics. So that should have been shared with all trust colleagues to start using with their local data to kind of start to unpick how that aligns with what has been shared from the MHSDS. In November, so today, the deadline for the submission of trajectories. And then we are also in the process of pulling together a second SQL script, which will support providers in using their full clock stop data. We're just in the final process of testing that with provider colleagues to make sure that that all works and is ready to be shared. And then we'll be doing a review of the trajectories and playing them back to our London Mental Health Board. So I guess from November onwards, waiting times will continue to be a focus for us in the region. We will continue to provide support to trusts on an ad hoc basis where you need it, particularly around DQ. We'll continue to monitor the trajectories for eliminating those extremely long waits. And I think just building on the point that Grace made, we see the full clock stop metrics for both adult and children, young peoples as being aspirational and where we want to get to. So we will continue to support systems, particularly around DQ and coding, so they can kind of accurately reflect all of the fantastic work that is happening and is being provided to our patients in the data. So I will leave it there for now and hand back to you, Kathy.
Thank you very much, Beth. And I have to say, I liked your slide that summarised the importance of data. I thought that was a very nice summary slide, and maybe I could use that with some of my team sometimes. I think there will be questions in the chat, and I'm sure that there are questions for you, which we'll save for the Q&A. I think for me, listening to it, I have questions about what support is required for the cultural shift that's needed in some of the services to get them to submit the data, and maybe we can touch on that, because I think everybody's very stretched and under financial constraints. There's increasing demand, and a lot of clinicians who are excellent clinicians don't see completing a measure or a metric as important as seeing somebody, and that's something that we do need to address. Anyway, moving on, thank you very much. I knew you're going to be able to hang around for the Q&A. Beth?
I will have to dial off at 4 o'clock, but there's Carolina's
I think
on our team.
it's in like 10 minutes or so.
Oh, okay, perfect.
Yeah,
yes,
that's fine.
I'll be around then.
Lovely. So I'm going to hand over now to Jenny Taylor, who I think is actually the person who's put together the plans for the day, and she's project manager at Transformation Partners in Health, and she's going to give us a little bit of an update, I think, on the insights and the evidence review that's been undertaken on this particular area. So Jenny, over to you.
Thanks, Kathy. Hi, everyone. Thanks for coming to today's webinar. Actually, Olya, if we can go to the next slide. So just want to kind of pick up kind of on from where Grace and Beth kind of left off. So over the last, I'd say, sort of 15 months or so, not quite 18 months, but sort of 15 months, at Transformation Partners in Health and Care, we've been pulling together a program to look at children and young people's waiting times in London. And the reasons for this is we wanted to understand what the current waits were like and what was the factors driving long waits. We also wanted to explore inequalities in access for those who were on wait lists, as well as work with young people from across London to learn from their experiences, but also to work on solutions. And the full point of this was for us to capture and share examples of practice, and then to share them, for example, on events like today, but we've also built a resource hub on our website featuring case studies and all the work that we've done. And just to say, I suppose the core asks are the ones that Beth and Grace have highlighted in the earlier presentations. And what we want to do today is, the presentation I'm giving today is about sharing practice and learning from the work that we've undertaken. So if we can go on to the next slide, please. And the next slide. So our approach was to kind of learn about the evidence around the impact of long waits. So we did some desk-based research looking into learning from young people, looking at examples of clearing backlogs, starting to think about looking at learning from the 4-week wait pilots as well. So we did quite a bit of an extensive desk-based research, and that led us on to do a quite significant piece of stakeholder engagement. So some of the key things we did to learn from the system was, first of all, we pulled together a youth board of young people aged 16 to 25, and they worked with us. They provided insights, shared their experiences, and really inputted into the development of the program. And it was great having the young people support this work. Alongside that, we did a piece of work to engage with the 4-week wait pilot areas. And we're hearing a bit later on in this webinar from Katie, who was one of the 4-week wait pilot areas. But we spoke to 9 areas, so 9 or 10 actually. So all 4 areas in London, plus another 5 or 6 outside of London as well. And we wanted to learn from those areas about what their key challenges were, what they've been able to sustain over time, and kind of to learn where they are now. So there was some great learning from that really pulled this work together. And alongside that, we spoke to other stakeholders, and we'll be hearing from another example today of an area that's cleared their backlog and their wait lists. And as well as we did quite a bit of work looking at support for young people whilst they're waiting, so waiting well support. Although a lot of people don't love that word, that saying waiting well. So support for young people on wait lists, we'll put it that way. And then the third thing we did to kind of pull this work together is we did a significant piece of work around data. So we worked with the ICB leads as well as the London region to pull together and find data on young people's mental health, and did an analysis of waiting times between 2019 and 2023. So it was sort of across that 5-year period. And we were trying to explore wait times in terms of waits to have initial waits, but also those hidden waits that we know are along the system. The other thing we did, and obviously there was some data quality issues, but we also looked at whether there was any disadvantages by different groups, by ethnicity, by gender, etc. And we've pulled out the learning from those diagnostic reports. And what that's enabled us to do all that work is to pull together an insights and evidence review, which is available on our website. And to pull together and capture examples of best practice, which I'll take you through today. So if we go on to the next slide. Oh, and the next slide, please. Oh yeah, this one's perfect. So just want to highlight some of the key findings from all of that work. And it really showed us, I want to talk, and I'll go into more detail in a minute, was looking at different approaches along the pathway, some significant inequalities that we found from the work. As well as some learning around demanding capacity and process and procedures, and then some key issues that came up. And I suppose some good learning, but also some key challenges around workforce. So if we can go into the next slide, I'll go into these in a little bit more detail. So there's much more information about this, and we'll share the insights and evidence review with you. But I've just kind of pulled up some of the highlights. So where waiting times have been successfully improved, sites have considered the whole pathway, as well as key models. So thinking about this along the pathway, a lot of areas really looked at the front door to their services, their single points of access. Teams did things like enhanced triage, or really reviewed and looked at their assessment teams to make those changes at the front door of the service to get young people assessed and into the right support as quickly as possible. And then moving along the pathway, a lot of areas looked at processes and procedures, patient flow, case management, things like that, to continue to move young people through services. There weren't those hidden waits along the pathway. And then as well, in terms of bottlenecks, there was just considerations around discharge and around length of support for different levels of need. And a lot of areas really supported their staff teams to think about how they can safely end treatment and step young people down from care. So there's some great examples of that. And there's more examples from the pilots in our, I haven't pulled them all out today just because of time. But you can check out the more information on our website around this. And then underpinning this all again is support for young people who are waiting on wait lists. If we go on to the next slide. I just want to pull out two key areas of inequalities that we looked at. So first of all, our data diagnostic reports pulled out some interesting information around waiting, and it showed that there are groups of young people who seem to be facing longer waits than others. And these include young men and young people from Black, mixed heritage, and Asian backgrounds as well. And then, as we've mentioned earlier on this call, young people as well waiting for neurodiversity services. But what I would say about that is there were differences. So there was a pan-London view, and then we looked at that further in the second day, report that we did. There are differences per ICB. So it's really important that everyone looks at their own, their own area. And then just secondly, on inequalities, I think I really want to mention one thing that the young people really highlighted as something that was really concerning for them. They were really worried that young people aged 16 to 18 might face additional disadvantage, depending on how old they are when they come to us for support. And is there scenarios where young people are on wait lists, turn 18, and then join an adult's wait list? So that was just something the young people were really, really concerned about in terms of if we're looking at this from an inequalities point of view, is that a significant disadvantage, the age you are when you seek help? So we'll just go on to the next slide. And apologies, I am cantering through this just for time, but we'll go on to the next slide. So we also found some interesting learning from the 4-week wait and other areas around demand and capacity modeling having a benefit on waiting times. So a lot of areas looked into demand and capacity modeling approaches where tools are utilized to help services really understand any gaps between their current capacity and the demand they're seeing. And as has been mentioned on this call a few times, we are seeing those increases in demand and are working in quite constrained time with, we're not necessarily getting more staff or more money in. So it's just thinking about that. But obviously demand and capacity modeling can help with business cases. Alongside this, though, there was also a lot of work undertaken by teams looking at job planning with staff to really identify how many clinical hours they had. And then as well, looking at skills mix of their staff teams and getting that right balance. So that was just some of the learning around demand and capacity, which I think actually segues nicely. If we can go to the next slide, onto some of the learning and I would say challenges around workforce. So as we've said on this call, I think it was really interesting to say that when I spoke to the pilot areas across London and across England, they all said that they struggled with capacity and workforce recruitment and retention back in 2018-19. Since then, and the people I've been talking to even recently are still saying capacity is an issue. And then one of the things the pilot specifically said is they did a lot of work around skills mix and getting the right balance of people in their team. But as soon as someone left, that just changed that skills mix and could change kind of their planning for their team. So there's some, obviously some challenges around that. However, some of the interesting learning that was brought up was teams really worked with their staff team when they were making changes to bring their staff along with them, because there was a lot of change fatigue from staff teams. So they wanted to make sure staff were really bought into some of the changes that we were making. For example, job planning can sometimes be seen as like performance driven instead of actually there as a mechanism to help support staff. And then, things like staff training, staff supervision, was really helpful, and some areas did around this is kind of building on the demand and capacity modeling, but around optimization and kind of reporting of clinical time. So yeah, that's kind of on workforce, and I will move on to the next slide just to pull out some more insights from the young people. One more slide, please, Olya. So we already talked about the young people's concerns around age. They also had some concerns about young people from racialized communities waiting longer than their peers for support. And there was some more broad concerns around the adultification of Black children, stigma, young people often likely to be dealt with by the police, issues around accessing support for different groups. And then there was the young people were, wondering about were staff representative of the communities that they were supporting. So that was just some more input from the young people's on inequalities. The other thing the young people talked about quite a bit was, I suppose, about what services were available. There was still a lack of awareness from the young people, and they were from all across London, just wondering about how they can find out what's available to them at in their local area. And then they were also hoping to have more two-way communication between services for things where if they no longer needed an appointment, could they cancel it? Was there flexibility to change appointments and things like that? And they felt that that wasn't as flexible as it could be, if that makes sense. The other thing young people highlighted, which is not specific to wait times, but it was something they were really concerned about, was they were just wanting to make sure that we're working across the whole pathway, and making sure that things are joined up so that young people don't have to retell their story, which is often triggering multiple times while they're seeking and receiving support for their mental health. So it's just that ongoing difficulties that I know we have with kind of young people having to often retell their story. And then lastly, I just want to highlight the young people were really, really interested in and had some great ideas about support while young people were waiting. So they thought this would be really useful. And they offered, there's more information in the reports on our website, but just a couple of things that they talked about that would be useful were offering different types of groups. And these could be digital, in-person, condition-based, or age-based, just for people to get together. They were open to digital support, including apps and forums to share support. They were also really interested in learning about the different types of therapy available. So just kind of having that information easily accessible. And they also were really interested in additional participation that they could get involved in to give them a greater sense of purpose, especially whilst they were waiting. So those are just some of the key insights from young people, and I'm conscious of time, so I will, if we can move on to the next slide. And then the next one. So just to kind of reiterate, the key asks are the ones that Grace and Beth pulled out, and our whole presentation is really about sharing learning, but some of the recommendations or key learnings that we pulled out from the work we did was that consideration of whole pathway approaches, thinking about waiting well support for young people, really looking at inequalities of those young people who are waiting within, obviously, because there are young people, we know there's issues around access and inequalities, but there's also looking like there are inequalities within the wait times as well. So it's just considering that. Thinking about models as well. It was interesting, quite a lot of the areas we spoke to in the 4-week wait pilot areas were, actually all of them were pretty much in some form of maturity around the I Thrive framework, which was an interesting finding. Obviously workforce challenges. And then one of the other things that was interesting is a lot of the teams said it was working with young people was not that easy at a service level around wait times. So yeah, if we can keep sharing any learning we have from young people around that, I think that would be great. And then again, it's making sure we're aligning to the work that Grace and Beth and all the teams are doing. So that core asks around the 104-week waits. And then I'll just move very quickly on to my last slide, which is just looking at next steps. So just to say that we have all of this on our resource hub. So the full evidence review that I've talked about, we have our data diagnostic reports. We have a report highlighting everything that the young people did in that work with us. We also have a webinar that we did earlier this year on waiting well. That's available. So just kind of, we'll send the link to the resource hub to everyone so that you have that to use as and when you might want to pick it up. And then just to say, we're continuing in our team to support the London area in implementing the I Thrive framework. And that's through the community of practice meetings that we hold. And we are still offering some ICB training as well. So I'll pause there. And if we go on to the next slide, it just gives our contact information as well. So for more information, but we'll send all the links with the. Thanks, Kathy.
Thank you, Jenny. I'm not sure there's much time back to me because I think the plan now is to move on to a little, a brief Q&A. So I know that there's been some questions in the chat. I think Jenny, you and Tim have been collating these, so hopefully you can help feed them in. But I think if you've got questions for Jenny, for Beth or Grace, are we going to do it through raised hands, or are we going to do it through questions? I think we could maybe go on.
We've blocked everyone's hands, so it is through the chat. So if people have questions.
Well, I know that I've been looking through the chat, and I know that there were a lot of questions early on about the the work that Grace presented and about what this means for the extensive weights that we've got for neurodevelopmental disorder assessments, so primarily autism and ADHD. And we know that there are a 2-year wait is not unusual, and I'm sure that that's the issue across the country. So I think there were a lot of questions about how the clock stop might be skewed by this. I don't know, Grace, whether you want to, you must have seen some of the questions, whether you want to just talk to this briefly.
Yeah, so in terms of, so those cohorts are included in both the contact-based longest wait, so the 104, and are currently included in the metric as well. We'll just talk about contact, because as I say, metric, we're parking for a bit because the data quality isn't great. In terms of the full metric, in terms of the contact-based longest waits, there was, in the 104-week wait template, there was a box where providers and systems could tick and say these longest waits are directly associated with ADHD and autism assessments. There was also a box for a narrative. As I say, I'm expecting, if not all systems and providers, to come back and say that, you know, this is where their longest waits lie. And then we will report that back. It's a very, it's been discussed at many levels of the organisation at the moment, so we are fully aware of it. And all I can say is we'll collect that, and then we will be able to report on next steps once we've been able to do that and take it to our leadership group. But we are aware. We're also, I've just got it. We're also aware of quirks where services have referred children, young people, say 17 and X months, to say an adult autism and or ADHD service, because you wouldn't turn them away and say, please come back when you're 18, and they're showing up in the children and young people longest waits. Again, frustrating, not your weights, but we'll build that. It's important to include that in the narrative so we can report that back. It's a kind of collecting mode at the moment to understand the picture nationally.
Thank you. That's very helpful. It's a really tricky issue. Jennifer, there are other questions. I'm just having a look what notes I've got. Is there anything you've picked up that people are asking? I know there were some questions. I don't know, Grace, Beth, whether either of you can answer around specifics of different populations. So you've just touched on neurodevelopmental disorders, but I think there were also some questions about LAC children. And I think one of the issues for LAC children is that they often move boroughs and then end up in different waiting lists and end up going back to the beginning of wait, you know, all of that kind of thing. I don't know whether there's been any special consideration for this group.
I know nationally there is a piece of work looking at that cohort. So unfortunately, I can't directly talk about that. I think ideally, a bit like I saw some questions saying, could we separate out, say, autism and ADHD cohorts into a separate dashboard? All things we would love to do and are very frustrated we can't do. We are just very pushed with analytical resource at the moment. But as I say, they're all being logged on a to-do list. They haven't been forgotten. I know it's not the answer you want, but we would like to be able to provide that, and we'll do as soon as we can.
No, I can understand that. Beth, was there anything you wanted to add to that? There may not be.
Yeah, I was just going to come in and say, I guess it's a really interesting question, isn't it? And I think, so you may or may not be aware that our regional director of NHS England is currently in the process of developing a London strategy for the NHS with the kind of executive NHS leaders across the city. And Caroline, our regional director, is really clear that children and young people is a top priority for her. Now that spans obviously much wider than just children and young people's mental health, but I do know that I think there are plans specifically to include in that a nod to the specific challenge you've identified around looked after children. So I think we would be really keen to, I guess, hear from system colleagues some of the specific challenges that you see. And I wonder if it's, Jenny and Shirley, something that we could pick up where we're kind of in the process of kind of scoping ongoing work aligned to the regional strategy and the regional mental health strategy as well, around what some of the potential opportunities might be around looking a bit more closely at the looked after children data.
Thank you, Matt. That's very helpful. And there's so many ways in which, if we were able to improve the data quality, this data could be fundamentally important to how we transform our services. I know one of the other questions that's come up a number of times has been around some of the inequalities that we know exist. So I think it's been highlighted about inequitable access. And I know from looking at my own system that we know that Asian children are underrepresented in referrals to CAMHS. And I know from some work I did in the provider collaborative that we get overrepresentation of white girls in inpatient settings and of Black boys under detention in PQs. So there is a real data skew around that. I think it would be really helpful if we could think about how some of that data could be used to understand why that is, and what services need to do to address that. I don't know whether anybody's got any thoughts on that particular issue. I think somebody had a question in here about it. Let me see if I can find it. I now can't see it. Oh yeah, is the data able to show the waiting times by cultural groups and ethnicity? So Grace,
I'd probably suggest, well, at the moment, I would doubt it, because I think we've, in terms of the contact-based data, waiting times data that we're using at the moment, because we're not there yet with the full metric, it is one contact based, hence why it contains so many cohorts outside of community mental health. It's age and consultation mechanism that we currently filter by. I know nationally it's on our list, and it's something we need to know more about and understand more, and there is a programme of work looking at that. So again, yeah, it's happening, it's just not ready yet, unfortunately.
And then I think there's one last question in the chat, but I think for me as well, it's how do we support a sort of culture change in services to get them to understand the importance of this. And I think that also links to the presentation that Jenny did around flow through systems and understanding what the barriers are within services, even to not just not completing the data, but we were talking about front door and understanding the front door, how we understand what goes on at the back door, so what the barriers are to people being discharged or and how that influences some of the data collection as well. I've got one question there's some questions in the chat, but Jenny, do you want to come in, and then we might need to wrap up?
Yeah, no worries. So the work we did, we were able to get some mental health data set, a cut from sort of Beth's team or the digital team at NHS London, and they gave us, so we looked at 2019 to 2023, and there was some gender data in there, and there was some ethnicity data. I would say that the data quality wasn't great in terms of, there was, I think, 20% no recorded ethnicity, but we were still able to pull out, I think, similar to what Kathy was saying, this Asian young people were waiting longer in ours. Some areas it was Black young people, and then longer waits by service as well. So I think there is sort of more we can do, and hopefully as the data quality, we can continue to work to improve that. But there might be something to think about, just more consistent, I guess, approaches across London and maybe beyond in terms of what we're collecting around ethnicity, so that we can really understand that. I think Beth's got a question as well.
Beth, are you adding to that?
No, sorry, I just meant to give a thumbs up to Jenny's point rather than put my hand up. But yes, for the record, I agree with you, Jenny. I think there's much more that we can do. I think ethnicity recording is actually like relatively well recorded in the MHSDS compared to some of the other protected characteristics. So there's definitely something that we can do to make sure that we've got consistency in all of the protected characteristics recording across the MHSDS. That will, like you say, will help us to have a clearer understanding of who is waiting, where are the biggest inequalities, and where should we be focusing our attention.
And I'm just going to move. So there's a couple of questions in here. So any questions that aren't answered, we will answer when we send the slide packs out. We'll pull together a bit of a Q&A, just to say, so if your question hasn't been raised. But there is a question here about voluntary sector involvement, and I think I had a question as well, as when we're thinking about waiting well and children waiting for services. I have a question about what they're waiting for. Is this just looking at waiting for sort of core CAMHS? Does it include educational interventions? Does it include social care? Does it include voluntary sector? Because certainly in my system, what we're trying to think about is a whole system approach to the huge increase in demand that we've had. We can't have everybody being funneled up to specialist CAMs. So do these metrics pick up across the system, or are they purely specialist mental health services? And then I'm going to suggest that's the last question because we're over time. Grace, you look like you're going to answer.
Yes, I was just going to say, if voluntary, if VCSEs flow to the MHSDS, we will pick them up, and that will be included in access and the contact-based longest waits. The issue we're having in terms of the referral spell, at the moment, that's joining up referrals within a single provider, hence why the kind of multiple provider issue is on our to-do list, because we know if referrals are coming in and out of different providers, then you can't link those up, and that that is a pathway that does happen and that we're aware of. So yes, if they're flown to MHSDS, which hopefully they should be, but we do understand the difficulties there as well, they will be counted in those metrics.
Thank you. That's really, really helpful. Right. I am aware that we're really quite over by 5 or 6 minutes, so I'm going to stop. I'm going to hand back to Jenny, who's going to introduce the case studies. And I think somebody was asking about if we got any good examples, and here we go with a couple of good examples. So over to you, Jenny.
Great. So I'll be really quick just because of time. We want to give Katie and Sophia enough time to share their brilliant best practice examples. So we've got Katie, who's going to speak next, who's a 4-week wait pilot area from Northumberland, who were the only one, which Katie will mention, that actually had a neurodiversity pathway as well. So I think really interesting. And then following on from that, once Katie finishes her presentation, we've got Sophia from the eating disorders team in Elft. So obviously they're on a slightly different measuring waiting times guidance than we're talking about today, but Sophia and her team and Kamal, they did such a great job in clearing their backlog. We wanted to share their approach as well. So I'm going to hand over quite quickly to Katie, and then we'll pick up with Sophia afterwards.
Hi everybody, thank you for having us. My name's Katie Paul and I'm a clinical manager within Northumberland SIPS. So if we can have the next slide please, and I'll deliver our presentation. So yes, what lessons have we learned from being a 4-week wait trailblazer site? Lots, and hopefully it might be helpful to some of you on this call today. Next slide, please. So where did it all start? Well, I'm sure you're all well aware. In 2018, there was a government response to the consultation on transforming children and young people's mental health. And there was kind of the green paper on next steps and a long-term plan. And it was about testing out approaches that how could we deliver a 4-week wait from an NHS perspective. I think one of the biggest challenges we had in Northumberland initially was we are not called CAMs in Northumberland, we're called SIPs. So everyone kind of thought this is our job. This is all of our services. We need to sort this issue out. And also there was the element of rolling out mental health support teams within education settings. Next slide, please. So as Jenny's already mentioned, we became one of the pilot sites for the 4-week wait, and we never thought we would have COVID in the middle of all of this going on as well. So that was an extra challenge that was thrown in for us. Next slide, please. One of the most interesting things is our demographics is very different to say down in London. So we're the most northerly county. We cover a huge geographical area. We're about 80 miles north to south and 55 miles across. And we are one team that covers that whole area. And there's lots of different types of how the population's made up. So we've got very vulnerable areas of Northumberland where they're actually quite resilient young children, and then we've got other pockets where they're more affluent, where we have more eating disorders and self-harm. So it's very interesting working where we work with lots of differences there going on that we have to be mindful of all of the time. And just to touch on that previous conversation about ethnicity, we have 99.9% compliance on ethnicity and demographics, and we do that at the point of the referral coming in, because we want to understand we don't have a lot of differences within ethnicity in Northumberland. It's normally a white British, but we're seeing lots of different people from different backgrounds, asylum seekers and things moving into our local area. So we're really trying to that's one of the main reasons we track this kind of ethnicity, and we'll have a big drive on that. So kind of when we first started, going back to 2018, access was kind of we all signed up, all of the health services that work with children and young people's emotional well-being was around no wrong door. So if someone went to the 0-19 service, which was school health, or the primary mental health service, which you could say is like a tier 2 type service, and then there's us as a specialist service. If it went to the wrong place, we would meet together and we would get it to the right place to cause no bounce. That did take an awful lot of time to get everybody on the same page, if you would like, and the voluntary sectors within that as well. And I think a lot of families want a ticket to the CAMS specialist service, and actually we need the voluntary sectors do some amazing work and can be a lot more responsive than some of the NHS providers. So a lot of work was done around kind of aligning ourselves to the Thrive model. And what we wanted was a child had a little issue, we're a little bit worried that they got the support there, and we stopped getting referrals saying, little Johnny's had low mood for 2 years. Well, what did you do 2 years about it? And we knew that it would take a long time to kind of iron out some of these issues. Waiting times, we identified some trajectories over the Trailblazer site of where we wanted to be at certain times to ensure that we got to where we wanted to be at the end, which actually was positive and it worked really well. Multi-agency working, which I've already briefly mentioned about the we all needed to sing from the same hymn sheet. We all needed to understand each other's referral criteria. We needed to know that there was no kind of, it could sit with both of us, you know, that grey line, and where would those young people go? And it was really important that we had a shared vision. So this shared vision was from the local authority, it was from education, it was from the voluntary sector, the ICB, and our trust's organisation when we put in the first bid to be that first 4-week wait Trailblazer site. And luckily in Northumberland, we were also successful in the mental health support teams, and we decided to put one team within a really deprived area and one team within a really affluent area, so we could see the difference and kind of work differently in both of those areas. And that really, helps relationships with all of us. We'll all just pick up the phone and we've got those amazing relationships now. And I think, truly embracing the Thrive model was key for us all. We, as Jenny's already said, we were one of the only pilot sites that incorporated the neurodevelopmental pathway, which in hindsight, was that a good thing? Was it a bad thing? I don't know. I'm responsible for the neurodevelopmental pathway. And actually coming out at the end, we had a 6-week wait for the neurodevelopmental pathway for an assessment to start. So, we did make some great headway. We're not there right now at the moment, but I'll come on to that later. In terms of flow, throughput and support of staff, that was something that was really important to us. We needed a stable workforce, and actually we're quite lucky in our team. Staff retire, they return back into the team, and we don't have a lot of staff turnover, which is really helpful. But actually we needed to upskill and train our staff, because the picture of the children coming in to the service was changing and becoming more complex. So every member of our team has a therapy. So we have around 90 clinicians working in our service, and everyone has their own area of specialism, and we all know who does what within the service, what age of child they're like. Every member of staff has a profile, which helps us allocate children to the right clinician with the right skills. The other thing was really about understanding the capacity and the demand of the service. So what caseload sizes do our staff carry? Actually, but then it's not just always about the number, it's about the complexity. So we have, everyone has a job plan, which I know has been touched on. Ours is very not as a performance thing. It's more around, have they got the time to do the work that the staff need to do? So we kind of expect a full-time band 6 to be able to do 17 hours of face-to-face clinical contact a week. So that might be spending 2 hours with somebody. That might be spending an hour with somebody, might be spending half an hour. It's that amount of time. And then they've got 20 and a half hours to do everything else. So admin, traveling around, emails, training, supervision, caseload management. There's a lot of things that we offer as support. And I think that was really key. So within our mental health and learning disability pathway, the staff carry caseloads of about 25. When caseloads start to get bigger, throughput slows down, and then you end up with a bottleneck. So that's a really key thing that we learned through this process. Next slide, please. So throughout the process, we had regular face-to-face meetings with the other pilot sites. They were in Birmingham and would go there for a few days. And we found that as really, really helpful. One thing in Northumberland, I think we're really passionate about it. We want to see children face to face. There was lots of areas where the first contact might have been a telephone call at the point of referral, where you've given some advice. But what children and young people were telling us, they like to be in a room with someone face to face. And we learned that through COVID as well. Like, you know, they like that dedicated space for them, not on an online call. We do offer that as well, but you know, that's something that we so every first contact that we have in our service is face to face, and is with a band 7 clinician within our team. We've also gone on to supporting other NHS sites, so Dorset, Norfolk and Suffolk NHS trusts, and that's through our links with NHS England and them kind of saying, this team's struggling, do you want to mentor and buddy them up? And you know, it's just been a real pleasure to do that. It's about working together. It's not just about this is a Northumberland issue or this is an issue down in London. We're all in the same boat. So yeah, those things were really important to us. Next slide, please. I have touched on that review of services. So these are just some of the services that we work with on a daily basis, and none of this would be possible. And it's about having that buy-in. We then created, with our colleagues in Northumbria Healthcare, there's the BU team, and that is the mental health support team. So we have our own local website, which is similar to Young Minds, but actually it's staff within Northumberland, little videos around kind of how to get children to manage a panic attack, how to, if you're feeling anxious, strategies, but it actually might be a clinician that's working in your school that day. So it's very familiar to the children and young people. And that website is for parents, carers, professionals and children and young people. So that was another real key thing as a source of support for our local community. Next slide, please. So kind of getting on to that access referral team and an assessment. We don't have a single point of access in Northumberland. And actually that's one thing that NHS England really liked about us. And so it's all band 6 mental health clinicians on our front door. We decided, instead of having all staff on a rota in the team, that we would go for consistency. So we moved workforce around in this team. This is all that they do every day, is review referrals, provide telephone consultation. We deliver 8 telephone consultations per day, and they're 45 minutes each, where we can a family could ring in, or a school or GP, anybody, and we can talk about the difficulties and get them to the right place. And if we feel that's a referral for us, that is all captured there, and that is the referral open that day to us. We also interface with our early help colleagues. They have a referral access point and they can refer into us on GPs or schools' behalfs. And then we have a children and young people's interfaces, which is where all the health services come together if a referral's gone to the wrong place, or it might be around sharing information. If someone's worked with them before, and that would be really helpful so people aren't telling their story again. All of our mental health and learning disability referrals are seen within 1 week, face-to-face in a base, and they are seen by a band 7 or above clinician. And following that, they are then allocated to a clinician with the right skills to meet that child's needs, and the family and the young person walk out that appointment with their appointment, and that is within 4 weeks. So that next appointment will take place in 4 weeks. There's a lot of work that goes on behind the scenes. We have a year's appointments mapped out. So we have every initial assessment mapped out for the year on an Outlook calendar where admin book them all in. And then that band 7 clinician in that appointment goes into that calendar and identifies the person with the right skills and books them in. So that's kind of how efficiently it works. We did at the beginning, all the neurodevelopmental pathway used to have a face-to-face appointment, but actually we were accepting them all and we were making the right decisions at the point of referral. So we changed that more recently to a welcome event, which I'll come on to a bit at the moment. If somebody comes to that initial assessment and we don't feel it's for us and they don't need a specialist mental health intervention, but they may need another service, we will discuss that with our other health colleagues or the voluntary sector and signpost them there, but we will do that all on their behalf. In terms of the welcome event, we have decided for the neurodevelopmental pathway that we wanted to deliver these in the family hubs. So we wanted to move them away from health and mental health. And actually, this is everyone's business. And this group of young children need their needs met, whether they have a diagnosis or not. And often the difficulties won't change after the diagnosis. And if there's a wait for that assessment, they need those needs met along the way. So there's lots of things available in the local area that children and families can access. And we've now got an agreement in the last 18 months where children can be seen by school health or the primary mental health service, but also being on our pathway for assessment. That never used to happen. So that's a big a change and a positive change for us. So in terms of getting children's mental health needs met at the same time is really great. Next slide, please. So support and staff. This is, I think, one of the most important things, because if we don't have the staff, we can't achieve any of the 4-week wait at all. So every member of staff has 1 day's protected time a month where they can do their mileage. They if they've just worked some extra hours, they need to put that in, but they also have time to go through their full caseload. Is there anything that they're waiting on? Has anything been missed? Just a time to kind of reflect on the caseload and think about things. They get management supervision. They all have a job plan with CPD identified time. They all have clinical supervision. We have a variety of MDT forums throughout the week. I think we have about 5 different MDT forums. We have a training program that's delivered every Wednesday morning that everyone's got protected time to attend on a variety of subjects, and people external coming in and talking to our staff as well. We offer a bespoke induction. It's very different working with kids and working with adults, and navigating for every 1 contact you have with an adult, we have 3 for a child, because the school want to know, the parents want to know, everyone wants to know what's going on. Caseload management, which is really important around understanding capacity and complexity, so staff don't get overwhelmed, and then their appraisal, which I'm sure everybody else has in their own services. Next slide, please. This is just one brief slide about referral and demand. So really looking at kind of our referral data, going back to when we first became a trailblazer site, COVID happening, and then this explosion of referrals. And what I would say is that explosion of referrals has probably been more around neurodiversity. And we're going to be doing some more work, which I'll come on a little bit later in the presentation, around kind of, I think some of those are duplicate referrals, because we might get a referral from a man, but we haven't got all the information. So we then close that referral, ask from school, and then it gets opened again. So I think there's some data issues going on there, but we've got an idea in terms of how to sort that out, hopefully in the future. In terms,
can I just stop you very briefly?
Yeah.
I'm aware we've got another presentation and we've only
Okay.
got about 15 minutes left. Jenny, what's your suggestion? I don't know how many more slides you have.
I'll skip this slide if you want and just go to the end if you want.
I'm really sorry to do that, and we can
That's
share
fine.
all your slides.
That's
but
fine.
I'm just aware of time.
No problem. If we can go on to just, if we go on to the current picture for today, I think it's the last one, current picture. So I've already mentioned about kind of the mental health and learning disability pathway are continuing to see their achieve their 4-week wait in terms of 2 appointments. The neurodevelopmental pathway are receiving their welcome event within 2 to 3 weeks of the referral coming in to ensure that needs are being met whilst waiting. And next steps mainly are around revisiting our referral criteria around the neurodevelopmental pathway, but also resetting the service, and we're going to be moving towards CAMS, being called CAMS again, and being kind of who we are, because I think nobody really knows what the Children Young People Service is, which kind of blurs some of the boundaries. Was a lot of recommendations from NHS England around patient tracking and things, but there's a lot of detail on those slides, so people can catch up on those themselves later. But if anyone has any more questions after, Michelle and myself's email addresses on the last presentation. I'm sorry I've taken so much time.
No, that's fine. It's really, really interesting, and I'm really keen to know how you've done some of this, and I might be in touch myself. I'm just aware of time.
No problem.
So please, I'm sure lots of people will be in touch with you. Jenny, do you want to move on for the final presentation?
Yeah, I think we can just move straight through to Sophia from the Eating Disorder Service in ELF. Sophia, if you're ready.
Yeah, hi, thanks. Jenny, do you have the slides? Sorry.
Yeah, if we go on to the next slide, it should be your slides. Yeah.
Oh, cool. Okay. Right, okay, so I'm the Associate Clinical Director for the Eating Disorder Service in ELF for children and young people. I was supposed to do this presentation with my co-lead, Kamal, but he's not around today, sadly, so you've just got me. But I'll try and make it as brief as possible because I'm just aware of the time. But essentially wanted to kind of share with you how we tackled our capacity and flow issues, namely our wait times into the service, and how we use quality improvement hand in hand with leadership, which I know is an interesting way of looking at things, and we think about leadership and take it for granted. But I'll go through quite quickly some of the kind of core themes and what we sort of worked on really. So if you don't mind going to the next slide. So we're quite a busy community eating disorder service in East London, working across 3 London boroughs, working with a very different kind of sets of communities from different ethnic backgrounds, different socioeconomic backgrounds, working across 3 different acute sites, 3 different local authorities, lots of different schools, different community organisations. So, you know, we're quite a dynamic sort of multidisciplinary busy team. We also have a hospital at home pathway within the service, looking after young people who perhaps in the past would have been admitted to Tier 4 psychiatric inpatient services. So the hospital at home pathway really offers an alternative to admission. So you can imagine we're working with really unwell young people, very worried families, and working across quite a multitude of different sort of agencies, including kind of paediatrics and medical teams as well. And as we all have felt during the pandemic, our eating disorder services across kind of London and England have reported large increases in referral numbers, an increase in acuity, lots of complexity. Can you move on to the next slide, please? And I guess locally, our service saw an increase in waiting time, namely from referral to routine assessment to 17 weeks on average, which is significantly longer than the 4-week national target for eating disorders, and significantly longer than our 2-week local target. Similarly, wait times to access treatment pathways within the service also increased. So even when young people were finally assessed and given a diagnosis, brought into the service, they had to wait significant amount of time, anywhere between 6 to 12 months, to see a psychiatrist and to access therapy. And you've got to remember that the family therapy is the sort of mainstay offer of treatment that we offer. So you can imagine just how worrying and distressing this is for the young person and family, but also the kind of impact waiting this long has on the disorder itself. So delaying treatment can kind of worsen prognosis, further entrench symptoms, impact long-term functioning. And no doubt you end up developing a bit of a culture in your service where you become really reactive because patients are waiting, they're then presenting crisis. So you're always sort of chasing and firefighting rather than thinking in a proactive sort of way. And no doubt this impacted staff morale, staffing, there was lots of sickness, high staff turnover, vacant posts, even to the point where the leadership structure also was impacted. There wasn't sort of a consistent kind of leadership structure or presence. So you can imagine what this might do to a service and a team and how it might feel to work in a service like that. So we're going back now, this is around sort of summer 2022. If we can go to the next slide, please. Myself, there was some changes to the leadership structure at that point. So I was appointed as the sort of medical lead back in sort of summer 2022, shortly after my co-colleague was appointed the non-medical lead. So that was the first sort of step towards improving the service, kind of looking at the structure of the leadership, I guess. But we kind of went in there with lots of energy to kind of look at the problem around the culture, the wait times, the capacity and flow through the service, and felt, well, this is our mission to kind of tackle this complex kind of problem. But also what was important to say is that we had the permission from the directors to kind of think outside of the box, think creatively, you know, and had their backing really to think about improving the service. So we went in there, we had this kind of concept in mind, Deming's lens of profound knowledge. So Deming is thought to be one of the fathers of quality improvement. So he was an American analyst, statistician, and did lots of work around quality improvement in lots of different types of organizations. He had this concept around thinking about really spending the time to do a deep dive to truly understand the system or organization that you're working in, and to appreciate the system and to look for strengths within the system, as well as looking at processes, context, culture, pathways, and this type of thing. So what we did was we set up a number of focus groups with the staff to really listen to their perspective and experiences on the ground, what it was like to work for this service. We also used service user feedback, both positive and negative, complaints as well as compliments, to really centre the young people's voices and then the families' voices, because we realised that that's quite a powerful motivator if you're thinking about change management within health. Staff always can kind of connect to the young person and family sort of voice. We also went in there with a very curious approach and a strengths-based approach. And we kind of, in parallel, worked on a strong recruitment sort of campaign to think about stabilising the team structure, the staffing structure, really. But we thought, given that it's quite a complex problem, the best way to kind of approach it was using a quality improvement framework to look at capacity and flow as a whole. So both the front door, the internal pathways, the discharge pathways, staff wellbeing as well, but with a particular focus on reducing wait times, which is what I'll focus on in the next few minutes. Next slide. So we used a concept called process mapping, which is something that we think about in quality improvement work, which essentially is it's quite a simple thing. It's essentially just producing a visual representation of the processes and steps within your pathways within your service. So we thought about the referrals pathway and mapped it out. What happens at the point of receiving the referral? What are the steps to then lead to the patient being seen? And it sounds very simple, but actually it's a really nice way to understand your pathway and to look at areas of delays, bottlenecks, duplication, where there might be extra steps in the kind of system, and it can sort of start to make you think about where you might make some changes to kind of improve that flow into the system. Next slide, please. From there, apologies, I know it's quite hard to see, but it's just to give you a bit of a flavour. We produced a driver diagram. So again, this is a concept within quality improvement work where you think about what might be the primary drivers that might be useful to look at when you think about your problem. So our problem was thinking about improving capacity and flow throughout the service. Our primary drivers were looking at the front door, internal pathways, the back door, and staff wellbeing. So in addition to the long wait times to access the service and to access treatment, we also had long waiting, long backlogs really of patients that needed to be discharged from the service, but there were hold-ups with getting a discharge processes done, with the letters getting done. We had a whole load of young people on the caseload that hadn't been seen in months. We weren't quite sure when they were last seen or what the care plan was. So, you know, you do get sometimes patients that get lost within your caseload, within your system. So there's lots of issues around sort of backlog. But for the purpose of the next few minutes, I'll focus mainly on the front door and what we did in terms of our referrals, wait times. So if you could go to the next slide, please. Thank you. So some of our change ideas, again, they weren't mind-blowing radical sort of ideas. They were quite simple ideas, really. So we started reviewing the referral form itself. Now, it's really interesting how as services we get used to working in a particular way. It can then introduce these sort of blind spots. So but by way of this sort of quality improvement project, we thought, well, let's have a look at the referral form. And we noticed that actually the referral form itself was very broad. It wasn't specific. And given that we're a specialist service, what ended up happening in our pathway was we'd spend weeks sometimes in triage, going back and forward between the referrer and us, trying to gather the relevant information that we needed. So we got rid of a couple of steps, and what we did was revamped the referral form itself. We did it in liaison with GPs locally, who were the mainstay of our referrers, as well as some of our local CAM services, to make sure it was comprehensive. So at the point of receiving the referral, we have most of the information that we need to make a decision on whether we were going to accept or close. And if we did need to gain more information at triage, we would give ourselves a 1 week time limit to get the information back from the referrer. Otherwise, we would close the case. So it was kind of introducing some timeframes, a bit of decisiveness to the system, and trying to gather as much information upfront at the point of receiving the referral. We also had some of the things that we introduced, like setting up weekly referrals meetings, using an action tracker, as well as moving from 2 assessors to 1 assessor, because we were finding that having 2 assessors meant there were unnecessary delays to actually seeing the family, because there was lots of back and forth in terms of agreeing a date to see the families. And we also ran a bit of a proactive recruitment campaign. And what we did there, and I know Jenny mentioned it earlier on, we did look at the job descriptions, you know, and we made a few tweaks to the job description. But more interestingly, what we did was we asked the existing staff, what qualities would you like to see when we recruit our next paediatric nurse? You know, and so we got a bit of that kind of qualitative feedback from the staff around what was needed to secure a robust, collaborative, you know, team. Some of the things that they mentioned were things like, well, we need staff that can role model for some of the junior members of the team. We'd like staff members that, you know, are able to contain the team, are able to contain families. And these kind of notions aren't necessarily written in a dry way, you know, on the job description itself. So it was quite interesting to get that feedback from the staff. Next slide, please. I mean, we had a whole host of other change ideas, but for the purpose of time, I won't go through each and every one. But we did run psychiatry clinics to clear the backlogs of those waiting. So we had about 75 families waiting for a psychiatry review. And we had this really interesting way of sort of internal referral, which is quite odd if you think about, you know, anorexia, you know, it's a physical and mental health issue. We have multidisciplinary teams. So we wanted to move from this kind of working in silos and having separate internal kind of referral lists and things to a bit more of a collaborative, joint working kind of dynamic way. So we managed to kind of reduce or get rid of our kind of internal wait times by introducing a bit of this sort of culture shift. We reviewed our therapy job plans. and really started to think about, well, what capacity does each therapist have? What is a reasonable number to have on your caseload in order to support sort of timely allocation? And we focused on reviewing those in therapy. We had some young people that were in therapy for 2 or 3 years, which we really it's quite difficult then to see, well, how are we helping if we're keeping them open? How is the work helping? So we really had to focus on outcomes and reviewing the progress of therapy. If people were facing a bit of a plateau, we'd have a little think as an MDT around what are the challenges to kind of progressing in therapy, and made decisions around maybe changing the approach or closing the case and offering something else. Next slide, please. So this is a graph. It's an X bar S chart, which essentially, if we look at the left chart, that's our mean weeks waiting from routine referral to assessment. And then you've got the chart on the right, it demonstrates the standard deviation. So essentially, you can see that our average wait time from routine referral to assessment was running around 17 weeks. That has reduced over the 1 year QY period kind of testing time down to 2 weeks, and you can see it's stabilized at 2 weeks. So that the latest data point really is March 2024 at the end of the graph there. So you can see that we really have embedded something in the changes that we made that has led to a sustainable change to the wait time, really. Next slide, please. I might skip over this just for the purpose of time, but essentially, yeah, I'll come on to the next one if that's okay. Next slide. So I think this bit is really important, just thinking about challenges and key learnings. Essentially, it's really challenging to think about how do you manage change in the NHS, particularly at times of financial viability is an issue, staffing is an issue, you've got poor staff morale, high demands on the service. But so these are sort of a couple of things that we do to kind of get people on board and develop their trust and kind of get them to think a little bit outside the box. So we used an appreciative inquiry approach, that is thinking about being curious to the system and curious to different perspectives and appreciating the strengths in the system and what we're doing well, because we can often focus on the problems and get really bogged down in the problems. We wanted to kind of encourage a solution-based, positive kind of approach to this. And by spending time with the staff and thinking about strengths, it really helped to build a bit of trust and get their buy-in a little bit. But also how you use service user and family voices as a lever to help motivate staff, because even the most kind of jaded staff member, something will resonate when you remind them about the staff, the young people's voices, or the family's voices, really. So keeping them central was really important for us. We really wanted to have a service user on the quality improvement project, but that was quite difficult to do. So we used other ways, like looking at complaints, compliments, and informal sort of feedback. And there's something about giving permission to think outside the box, to your team for the best interest of the service users. If you go to the next slide, I think it's my last one. So one of the things that really struck a chord with us is something called high impact leadership. So the IHI, the Institute of Health Improvement, who do, they lead lots of quality improvement work in healthcare, and we're in Elft, we're affiliated with the IHI, so we hear from them quite a lot. They talk about core behaviours that are important to kind of improve care, improve health of populations, and to improve costs. And they talk about these 5 kind of pillars. They describe it as patient-centeredness, frontline engagement, relentless focus, transparency, and boundarylessness. So this is the way we sort of, I guess, interpreted that, and how we used that to effect change in the service is we kind of provided a bit of a persistent leadership presence and visibility. So there's something about being present as the leader to contain the team, to kind of be consistent in your messaging around your model or way of working for reassurance, but also to bear witness to the staff that we're with you. We can see the challenges and you're on the ground, so you can get a deeper appreciation of what's going on. We were very clear about the clinical model, and kept repeating the messages over time. No, this is the model, and this this kind of thing. This is why we're doing what we're doing. This is what we're commissioned to do. But also centering young people and families and keeping them at the heart of it. Being creative and thinking outside the box, but also trying to work towards a less reactive way of working, which I know it's really difficult in the NHS, but trying to build in capacity. So you're thinking about sustainability. So a part of that is, of course, you need to manage the clinical demands, but also how do you build in those key things that are helpful for staff development, supervision, learning together, reflection, and things like this, really, so that whatever changes you can embed, that they're embedded over time and they're sustainable, really. And that goes hand in hand with financial viability, or at least there's an overlap with financial viability as well. And of course, this helps improve staff well-being as well, keeping their well-being in mind. So I'm sorry that's been a really kind of like brief, rushed kind of distilled version of the kind of work that we did, but essentially that's everything. I think there might be one more slide to summarize, and then I'll finish, I think. Yeah, so we used a QI framework hand in hand with high impact leadership within a context of setting a clear vision for the service and investing in opportunities to build the will for change, maximising on those opportunities and creating the capacity to undertake the improvement work in the first place. And this yielded positive results that we've used to shape the culture of the service. And we continue to kind of put quality, innovation and systems thinking as a key function of the team.
Thank you,
I think that's it from me. Thank you.
And I have to say, I knew all about this because Sophia works in ALFT with me, and it has been a hugely impressive piece of work and it's been recognised in other places. So I think you won an award at the Royal College. I have to say both presentations are really impressive, and I think really highlight the importance of a belief that you are able to make a change and going about it in a systematic method.